Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. Before we begin our official grand rounds, just a reminder that we do have our big 100-year century and celebration on November 1st, and tickets are on sale, as well as information about the full day of discovery, starting with our amazing grand rounds with the former chairs. Just go to our website, the Department of Medicine website, and you'll see lots of links to help you navigate the day. And, just think about buying a table. There is a little discount, I think, if you get a table for learners or, your lab team or whatever. It promises to be a great evening with our own Department of Medicine band playing at the end of it. So looking forward to it. All right, so without further ado, I'd like to introduce Dr. Oliver. Most of you will know Dr. Oliver. She did her medical school training at Cummings School of Medicine in Calgary. She did her internal medicine and her hematology subspecialty training at the U of A. Her clinical interests include thrombotic microangiopathies and complement-mediated disorders, with a particular emphasis on paroxysmal nocturnal hemoglobinuria. She also has an interest in apheresis medicine with a focus on QI. She was the 2021 recipient of the Marshall Elliott Fellowship Award in Hematology, which she used to complete a clinical fellowship in complement disorders and apheresis at the University Health Network in Toronto. She's since returned to Alberta and assumed the position of staff hematologist and assistant clinical professor with a cross appointment as apheresis colleague in the Division of Hematology at the University Hospital. So without further ado, Monica's going to present on, I still did it.
It's okay.
Is going to present on paroxysmal nocturnal hemoglobinuria, identifying, diagnosing, and managing a rare hematologic condition.
Awesome. Well, thank you all. Thank you for the opportunity to speak today. I'm very excited to chat with you about one of my big passions, PNH. I do have a number of disclosures, mainly in the complement space. So I do receive advisory board, travel, and speaking honoraria. And I am involved in a number of clinical trials at our site, looking at new complement disorders. Objectives. So my objectives are to discuss PNH, the signs, the symptoms, the typical manifestations, and then hopefully leave you with an approach of when to test for PNH and how to recognize PNH in your practice. This is a rare disease, but we have a broad audience. And so I'm excited to hopefully maybe make some new diagnoses after we've gone through an approach. And we'll talk about the CATCH criteria, which is an acronym that can help you remember signs and symptoms of the disease. And then finally, to discuss some of the treatments of PNH and PNH-associated thromboembolism. And one of my personal objectives is to not go into labor because I am very, very pregnant. So let's start with a little bit of background. So what is PNH? So some people may be, intimately seeing PNH like me, or this may be something that you have to dust off a lot of cobwebs from back in medical school. PNH is an acquired ultra-rare, benign clonal abnormality of the stem cells. And it's an extremely rare disease. The incidence is estimated to be about 0.5 to 1 per million people per year. And it was named due to this belief that hemolysis, which is the red blood cell breakdown, and the hemoglobinuria, which is free hemoglobin released into the urine, which presents as that kind of dark red urine, happened intermittently, so with paroxysms, and with greater frequency during the night, so nocturnally. That being said, we've now learned that this is a bit of a misnomer. The hemolysis happens all the time, although patients may notice it more in the mornings because they've been hemolyzing all night, and so their urine tends to be darker in the morning. And this was a very, very tragic disease. Without access to the treatments available today, up to 35% of PNH patients would die within 5 years of diagnosis due to disease complications, and a median survival was only 10 years. And as somebody who comes also from the malignant space, this is a pretty horrible diagnosis and prognosis for a quote unquote benign condition. So a bit more about the epidemiology. So this is a disease that does not discriminate. It affects men and women equally, and it can affect people of all ages, but fortunately is rare in children. But it does affect primarily young patients. So most patients are diagnosed in the third decade of life, with the median age of diagnosis of 36. And the incidence does increase with age. And then the global prevalence is about 10 to 20 per million individuals. And it most frequently is seen in Asian countries, although pretty close to what we see in Western countries as well. So now getting to the nitty gritty, so at the level of the genes, the primary defect in PNH happens in the PIGA gene for the majority of patients. Now, there are other genes that can be affected, but the PIGA gene is the big one to remember. And this is located on the X chromosome. And this defect essentially leads to the absence of these really important complement chaperone proteins. And so these are important proteins that help to stutter red blood cells, namely CD55 and CD59, and protect them from our immune system, namely the complement system. The mechanism why this happens for the gene mutation is totally unclear, but we know that once this mutation kicks off, we have uncontrolled, unregulated activation of the immune system's complement cascade. So essentially the fire is lit without any way to turn it off. And this can arise a number of different ways. It can arrive classically or de novo or spontaneously, or we can see this in the setting of other bone marrow failure disorders, namely aplastic anemia, MDS, and other myeloid neoplasms. And so if that made absolutely no sense to you, let's try pictures. And so the image on the left here is basically a pool of hematopoietic stem cells. And what you see here is that there's one measly stem cell which has that PIGA gene mutation, but it goes on to clone itself. And so that clone expands essentially. And then all of those itty bitty stem cells grow up to be the champions cells that they're going to be. So they could be erythrocytes or white cells or platelets, and they carry with them that PNH clone. So now I know it's very early in the morning to talk about such a cascade, but the complement system really usually fits in with the Krebs cycle, and the coagulation cascade is something people want to forget from medical school. But I was kooky enough to do a full fellowship in it, so we have to talk about it today. So the complement system is a very key element of our host innate immune system, and it's involved in surveillance and defense. And every time you look it up, there's new proteins that are that have been discovered. But right now we know it consists of at least 50 different proteins, most of which are synthesized in our liver. The primary functions of our complement cascade are cellular lysis by opsonization. What does that mean? Well, that is essentially coding of various pathogens and then sending them for destruction. In the case of PNH, that happens to the red blood cells instead. It also helps to generate a very potent inflammatory response, and it helps to modulate our adaptive immune system. And so we can look at all these very, very complex diagrams, but I really like to go back to this one because this really highlights the key points. This is the complement cascade in all of its glory. And I want to orient you a little bit to what you're seeing here. So the top of the diagram in that navy blue is the proximal complement cascade, so the top of the cascade. And then in the gray here is the terminal or distal part of the complement cascade. And there's three pathways of entry to kick off this process: the lectin pathway, the classical pathway, and the alternative pathway. But they all converge at a very important protein called C3. So C3, as you can see here, I don't know if you can see on the image, it doesn't look like it, but C3, as you can see there, is broken down into C3A and C3B by an important convertase. C3 convertase. And C3A is a weak anaphytoxin, so it basically starts recruiting an immune response. But C3b is the mischief maker. So C3b goes on to activate terminal complement, and namely an important protein called C5. C5 is further broken down with C5 convertase into C5a and C5b. C5a is a very potent anaphytoxin. It is pro-inflammatory, it activates endothelial cells and leukocytes, and it's extremely prothrombotic. But C5b has the ability to recruit other proteins. And so there's this Plinko effect where C5 activates C6, 7, 8, 9, and the complex of C5 to C9 is something called the membrane attack complex. And the membrane attack complex I described to my patients is like a big hole punch, and it's meant to go around and basically attack these important pathogens. But in the case of PNH, it actually attacks the red blood cells. And so normally we have checks and balances in place to regulate this complement cascade, namely these important proteins, CD55 and CD59. But in PNH, these are lost, and that leads to significant destruction of the red cells, the hemolysis that we see in this disease. So looking again at some pictures, on the left-hand side, we have a patient who does not have PNH, and you can see those red blood cells are beautifully, handsomely studded with those GPI anchors, CD55 and CD59. And then on the right-hand side, you see this bare naked, lonely, vulnerable RBC. And what you can see there is that without those GPI anchors, that red cell is really vulnerable to destruction by the complement cascade. And so that cell bursts apart, it releases free hemoglobin, and free hemoglobin is bound by nitric oxide. Nitric oxide is a very potent inflammatory agent, but it also helps. But it also helps with vasodilation. And so when you have consumption of nitric oxide, you have vasoconstriction. So let's talk a little bit about the signs and symptoms of PNH and how we recognize them. This is a disease that often goes undiagnosed for a long period of time because the symptoms are fairly vague and they're fairly common. And you've probably seen them a million times in your practice, but the etiology is not PNH. So the majority of patients present with fatigue, at least 80%, and I would say that's probably underestimated. As I mentioned, we have the scavenging of nitric oxide, and that results in smooth muscle dysfunction. And so patients can present with things like pulmonary hypertension, severe crampy abdominal pain. Associated with that, they can also have erectile dysfunction in male patients, almost up to 40%, back pain, dysphagia, so difficulty with swallowing, or esophageal spasm. There's a number of different ways that people have end organ damage, but it's really broken down into three major end organ causes. Up to 47% of patients will actually suffer from pulmonary hypertension. And then a majority of patients will also go on to have thrombosis, and that is the most deadly kind of consequence of this disease. And then 8 to 18% of patients can also have death as a result of renal failure. So the next question is, well, what does PNH look like in my practice? None of those symptoms seem particularly suspicious. So how might these patients present? Well, we have a broad audience, and so I thought I would go through some of the different specialties and how you might see patients present in your office. So in the neurology sense, patients can have migraine headaches or chronic headaches, maybe associated with the severe anemia, and they can have clots, as I mentioned, things like cerebral vein occlusions or cryptogenic strokes in young patients. From a urology perspective, these patients could have erectile dysfunction, or they have chronic hemoglobinuria. That free hemoglobin is released in the urine, and that can be mistaken as hematuria. From a pulmonary perspective, shortness of breath, pulmonary hypertension. GI, I mentioned that chronic, severe, crampy abdominal pain, as well as dysphagia and esophageal spasms, or clots in funny places like Budd-Chiari syndrome or mesenteric thrombosis. Nephrology, they could either have acute or chronic renal dysfunction. Cardiology, they could have angina or even an MI. And then in hematology, primarily what we see are the cytopenias, the hemolysis, the blood cell breakdown, and then of course the thrombotic complications. So PNH has a substantial negative impact on quality of life. And I like this data. This is from an international PNH registry where 23% of patients actually reported their quality of life as being poor as a result of this disease. And over 3/4 of patients, 76%, in a multicultural study actually were forced to modify their daily activities just to manage their PNH. So they couldn't do the things they wanted to do in a day as a result of their symptoms. So this has always been an area of interest of mine. And in many clinical trials, we use a indirect score. It's called the FACIT-Fatigue questionnaire. And it's a questionnaire that really looks at one facet of quality of life, which is fatigue. But I said, this is not enough. This is not just what my patients are telling me about. There's more than just the fatigue. And so I had the unique opportunity to help create my own questionnaire with Dr. David Sella, who actually helped to create the FACIT-Fatigue score, as well as a few of my colleagues. So we created this questionnaire. It's 9 questions, and we call it the PDQ, which is Patient Derived Questionnaire, or more colloquially, it's the Pretty Damn Quick Questionnaire, because we actually can get it done in clinic. And it really looks at particular facets of quality of life specific to PNH to help objectify the patient experience a little bit more. And so I wanted to walk you through just 2 cases just to sort of keep you all awake. And so I wanted to talk about Jack. Jack's a patient who I actually just diagnosed within the last month. And he was a pretty healthy guy. He presented to me with anxiety, and he was just on some escitalopram for that. And he actually had a 4 to 5 year history of intermittent severe abdominal pain and functionally limited fatigue. He's this really young guy, and he was just tired all the time. And he also said, every single time I get a viral illness, I look more yellow and my urine goes a really funny color. And he said this happened quite often because he had 2 little gremlins at home, and his wife was a kindergarten teacher. So he had viral illnesses not infrequently. And he went to his family doctor initially, and he was found to be iron deficient. So his ferritin was 10, his iron was 3, a blood film was done, it was totally unremarkable. His other vitamins were normal, so vitamin B12, folate, TSH, his creatinine, his liver enzymes, all normal. His bilirubin was just up a smidge at 22. And his CBC showed essentially microcytic anemia. His hemoglobin was 115, platelets normal, white cells normal. And because of this iron deficiency, he was screened for celiac disease, that was normal. And he had a urinalysis, and that showed 2+ blood. And so this family doctor said, this looks like iron deficiency. That explains why you're so tired. I'm going to start you on some oral iron and a laxative to go with it. And then I want to contrast this to a case that I learned about when I was in Toronto doing my fellowship. This was a 33-year-old female, and she had a past medical history of miscarriages. She had a TBI, unfortunately, with seizures, and it also had some iron deficiency, and she had been on lamotrigine for this. And she actually presented to the emergency department on multiple occasions, but this time, when she presented, she had a 4 to 5 week history of intermittent severe abdominal pain. She also had nausea and vomiting. And as I mentioned, she had been in the emerge several times. An abdominal x-ray was done. It showed some mild fecal loading. A pelvic ultrasound was done. It was normal. And she had a beta HCG. She was not pregnant. I can't say the same. And she had creatinine and liver enzymes were within normal. And her CBC showed iron deficiency. She had an MCV of 79, her hemoglobin was 105, her ferritin was 9, her platelets were down just slightly, and her white cells were normal. And she was started on oral iron supplementation and a laxative and sent home. And so with those cases in mind, I want to talk about the most deadly complication of PNH, which is thrombosis, especially to this audience that sees thrombosis quite a lot. Now, we could have a very long discussion about the interplay between the coagulation and complement cascades. We could do a whole talk on it, but I would send you all to snoozeland. And so we'll break it and distill it down and just to some major themes. So when we think about thrombosis in PNH, there's a number of different mechanisms. I've talked about this complement-mediated hemolysis. I talked about that there's endothelial injury and platelet activation and this big profound inflammatory response that comes from the cascade, but there's also issues with that nitric oxide bioavailability, as well as the fibrinolytic system, which becomes dysfunctional. And so I love this quote because it's very dramatic, so it fits my personality. And it says, we can safely say that PNH is the most vicious acquired thrombophilic state in medicine. And I certainly agree with that. So thrombotic events in PNH happen about 30 to 45% of the time, 10% actually at presentation. And most commonly, we're going to see clots in common places, DVTs and PEs, but we also have increased involvement of atypical sites as well. And visceral and CNS thromboses actually can precede and actually lead to a diagnosis of PNH. So clots in weird places, that usually trigger someone to think something else is going on. This is the leading cause of mortality in patients who are untreated or undertreated. 40 to 70% of them will pass away. And that first thrombotic event can be fatal, and it increases the risk of death 5 to 10-fold following that first thrombotic event. And the other thing that's extra scary is that subclinical thromboses can actually go unnoticed. And so I love this data. It's old, but I think it is really impressive. This is Anita Hill and colleagues out in Leeds who I've had the opportunity to meet. And this looked at 10 patients with PNH. This was prior to the advent of complement inhibition. They had a median age of 32, so young patients. They had been diagnosed for 2 years. They had a large PNH clone size. And they actually just went and scanned these patients who were asymptomatic. And shockingly, 60% of them actually had subclinical PE. And 20% of them had evidence of myocardial scarring. And these were asymptomatic patients. So a lot is happening behind the scenes. So where do we see thrombosis in these patients? As I mentioned, DVTs and PEs are still very common, but clots in unusual places happen as well. So hepatic and portal vein, 16.9%, mesenteric vein, almost 19%. And then you'll also see clots in unusual places like cerebral or IJ, and sizable proportions, so not insignificant, actually have arterial events. And shockingly, thrombosis can occur in multiple sites in up to 20% of cases. And so, as my pager went off, I'm on service right now for hematology, and we often get this consult for clots in young patients, so unprovoked clots, or for example, cryptogenic stroke, and we're asked about hereditary thrombophilia workup. They said, can we send a protein C and protein S? That's a discussion for another day, but I usually don't get the call about can we send PNH or should we send PNH? And I like this graph because this shows the relative risk, right? So we're worried about factor V Leiden. We'll look at PNH in terms of relative risk. And so the relative risk of thrombosis in a PNH patient is actually 62-fold greater than that of the general population. And we know that if patients have thrombotic events, as I mentioned, it's associated with increased mortality, and that's displayed beautifully here on that Kaplan-Meier curve. So what happened with Jack? Well, Jack kept going back to his family doctor. He kept just saying, I'm so tired, despite even being on this oral iron. And remember, his workup was essentially unremarkable. And so the referral process got kicked off. So he was referred to GI for this refractory iron deficiency. And a colonoscopy was done, and subsequently a gastroscopy was done, and both were unremarkable. And so he actually went for CT enterography, and that was also unremarkable. Because of this history of having this dark urine, he had an ultrasound KUB, no stones were done, so he was sent to urology at our site. And urology did a flexible cystoscopy, that was unremarkable. And so the impression plan taken directly from the urologist notes was, given these episodes are almost always associated with a systemic illness, I wonder if he's having a renal issue, maybe suggest referral to nephrology. And what about Anna? So remember, she had the 4 to 5 weeks of the severe abdominal pain back and forth to the emergency department. She was started on iron. And this time she comes back to the emergency department, but this time her pain is very severe. She has fever, she's hypotensive, she's tachycardic, and imaging is done, which shows an occlusive portal vein thrombosis. It's extending into the splenic vein, the SMA, and a non-occlusive IVC thrombus. She has no masses, she has no obstructions, no other anatomic explanation for these clots. And when her blood work is repeated, she's significantly more anemic. The hemoglobin is now down to 71, her white count is up a little bit, and her platelets are down just slightly, and her blood film just shows iron deficiency. Her liver enzymes are up, in keeping with her clot, but an LDH is also done, and this is up significantly, 785. Her haptoglobin's undetectable, but her DIC screen is normal. There's no evidence of DIC going on. So she was admitted to GI. She was started on unfractionated heparin, and because her clots were so severe, she actually underwent catheter-directed thrombolysis. And so hopefully at this point, your brain is tickled and you're thinking about patients in your practice or patients you've seen who maybe might, be worthwhile having a testing for PNH. And so we need to talk about how we're going to diagnose this. And if you do have a patient who you think may have PNH, or at least the diagnosis should be considered, don't worry, because this is a very hard diagnosis to make because you need to have a high index of clinical suspicion, and it is extremely rare. But it is very tragic to know that 62% of patients will take 1 to greater than 5 years before they're diagnosed. So less than 40% of patients will actually be diagnosed within the first year of presentation. Shockingly, 80% of patients are going to encounter multiple physicians on their journey to being diagnosed, and almost 40% of them are going to see more than 5 physicians and specialists before somebody considers a diagnosis of PNH. So when should you think about PNH? Well, unexplained thrombosis. Now we see that all the time, unprovoked PE, but think about it when you see unexplained thrombosis despite anticoagulation, especially in young patients, and in funny sites and in unusual sites, hepatic veins, cerebral veins, mesenteric veins, dermal, subclavian. Also, if you have evidence of hemolysis, and so our hemolytic markers, LDH, retic, bili, haptoglobin. So certainly if there's evidence of hemolysis and thrombosis, it should be on your differential. And then any other coexisting lab findings. Do they have cytopenias? Are they anemic? And I've talked about the iron deficiency, and just to explain that iron deficiency comes from the free hemoglobin, which is released, and it's basically excreted out in the urine. And that's why those patients have iron deficiency. And this hemolytic anemia is DAT negative. So it's not autoimmune driven and it's not a MAHA process. You're not going to see schistose on your peripheral blood smear. And of course, it's associated more in hematology land with bone marrow failure disorders. So we need to consider this in our aplastics and our MDS patients. And a group of people much smarter than me came up with the 6 Ps, which are PEP, paroxysmums, pallor, pulmonary, pain, and penis, to remember all of the other manifestations outside of thrombosis that may want to trigger this. And this in the bottom right here is just essentially what the urine looks like for a patient who's grossly hemolyzing. So the diagnosis I want to emphasize here. So it's hard to consider, but once you consider it, it's really easy to make. It does not require a bone marrow biopsy, and it's done on simple blood work that anyone can order. And it is flow cytometry, which is readily available, and like I said, can be ordered by anyone. So flow cytometry, as a reminder, is a laser-based technique, and this detects the expression of surface and intracellular molecules to help identify and characterize cell populations. We use a specific substance called FLAIR, and FLAIR helps us identify the absence of those GPI anchors that we talked about at the beginning, so CD55 and CD59. And when you get a PNH report, they'll talk about the red cells and the white cells. The red cells, we look at how many markers are there and we separate them into type 1, type 2, and type 3 populations. But the white cells, we just separate into monos and granulocytes. And we like to, well, me specifically, I like to zoom in on the white count because really the white cells are much, much more reliable. Number one, they're not going to be affected by transfusion. And also the white cells are not bursting and breaking apart like the red cells are. So their lifespan is preserved. So they're much more reliable. And so we can put this all together into this really catchy acronym called the CATCH criteria. This helps us catch PNH. And so we should think about PNH and send that easy flow cytometry test with patients who have cytopenias, aplastic anemia, perhaps unexplained thrombosis, a Coombs or DAT negative hemolysis, and hemoglobinuria. And really, if we can catch these diseases, we can really prevent a lot of the downstream end organ complications and optimize patient outcomes. So what ended up happening with Anna? Well, Anna, as you remember, she had that really significant intra-abdominal thromboses. Unfortunately, that catheter-directed thrombolysis was complicated by a hemoperitoneum of 2.5 liters. Her anticoagulation was subsequently held, but she developed an abdominal compartment syndrome, and her thrombosis kept progressing because her anticoagulation was held. Eventually, hematology was consulted and thought about the diagnosis of PNH. It was sent, and she had a large granulocyte clone of 58%. She was started on anti-complement therapy, eculizumab urgently, but unfortunately developed multi-organ failure and a large subdural hematoma, and unfortunately was declared brain dead 4 weeks after admission. Very young patient, she was 33 years old. And what about Jack? Well, Jack is still on his journey. So now he's been referred to nephrology. And nephrology does a urinalysis. It dips positive for hemoglobin, but it has no objective RBCs on microscopy. And so this very smart nephrologist says, well, the absence of proteinuria leads away from a diagnosis of glomerulonephritis, but given the synpharyngitic nature of hematuria, he could have IgA nephropathy, but his renal function is normal. And so the risk of kidney biopsy here would outweigh the benefits. I'll see him again in a year. But he goes back to his family doctor. He's now seen urology. He's now seen gastroenterology. He's now seen nephrology, and he's still really darn tired. And his CBC now shows that his hemoglobin is 122. His platelets are 145. His white count is normal. So if anything, his hemoglobin's actually gotten a little bit better. But for whatever reason, this family doctor decides to do more of an anemia, more of a hemolysis workup, and the LDH comes back at 898. His hapto was undetectable, and he was referred to hematology. And I saw him in clinic, like I said, just within the last month, and I was like, you have PNH. Go downstairs and get flow cytometry. And I called him within 48 hours to tell him that he had PNH with a very large clone size of 95%. So 4 to 5 years suffering of symptoms, all of these different specialists. And at the end of the day, it was PNH. So how do we treat this beast, PNH treatment? Well, there's a couple of different pillars. We start off with supportive care. So patients may be significantly anemic. The cases I showed you, they were very mildly anemic, but patients can present with rip-roaring hemolysis. And so we support them with red blood cells transfusions and then hematinic support, so folate and iron. Now, of course, if we're transfusing patients aggressively, they may become iron overloaded, and then you've got to switch gears and think about iron chelation. Analgesia is important. Some patients will actually require narcotics just to manage the abdominal pain. And then thrombosis, what do we do if these patients have a thrombotic event? Well, we start therapeutic anticoagulation immediately, but please know that that is not enough to protect these patients. And if we have patients who are newly diagnosed, especially if we're navigating funding for their complement inhibitors, I put them all on therapeutic anticoagulation, so primary prophylaxis, so prophylaxis, but with therapeutic doses. This is a Canadian and UK practice. We don't have a ton of data to support that this prevents clots, but it certainly makes us feel better because we know they're so high risk. There is a cure for PNH, which is allogeneic stem cell transplant, but our treatments are so darn good, we almost never need to do this. The only time we really consider the morbidity and mortality of going through a stem cell transplant is when patients have other bone marrow failure disorders, so aplastic anemia and myelodysplasia. In those cases, we essentially can cure 2 diseases with 1 transplant, and so we will consider it. But the mainstay of treatment is complement inhibition. And so if you think about that complement cascade we showed at the beginning, let's get really spicy and turn it horizontal instead of vertical, just to make things interesting. So this is exactly that same cascade, but just shown in a slightly different way. And this shows the 3 approved treatments currently that are funded in Canada and specifically in Alberta. So eculizumab, which you may be aware of, that's been around the longest, that acts at C5, which is the terminal part of the pathway. Ravulizumab is newly approved, and then pegcetacoplan, which acts higher up in the pathway at that important proximal protein called C3. So as I mentioned, eculizumab is the one you probably are most familiar with. This is a monoclonal antibody to C5, as I mentioned, and this prevents the cleavage of C5 to C5b, and that prevents all the downstream trouble that happens when that terminal complement complex is formed. This is an IV treatment. It's given weekly for the first 4 doses, and then every 2 weeks thereafter. And importantly, this helps to control the hemolysis, which drives the pathobiology of this disease, but it's not curative. And so these patients have to stay on therapy indefinitely with this inhibitor. All of the complement inhibitors I'm talking about have a black box warning for meningococcal meningitis. And so all of our patients have to be vaccinated. The vaccination itself can actually kick off the hemolysis. So we vaccinate them on the first day that we give the medicine, and we cover them with antibiotics, prophylactic anti-meningococcal antibiotics for the first 14 days. In my patients, I talk to them actually about indefinite penicillin prophylaxis. So eculizumab essentially has been shown, this is old data now, this was actually approved in Canada since 2009. So the TRIUMPH and the SHEPHERD studies were the big phase 3 clinical trials. And essentially what you can see here is a really beautiful improvement in LDH. So that's control of the intravascular hemolysis very quickly after starting the treatment. So usually within the first couple of weeks. 88% of the LDH will be reduced within 1 month after treatment, and there was an 87% decrease in hemolysis, which was maintained for 36 months in the initial trials. And this also helps with thrombosis. So there was a 92% relative reduction in the number of thrombotic events with eculizumab. It also improves survival. So on the left, a Kaplan-Meier curve, huge gap between age and gender matched controls in patients with PNH, and then those curves really gorgeously coming together. But this is a hard medication to administer, especially in our country, because they need to travel every 2 weeks back and forth for these infusions. And I have patients in Northwest Territories where the drug cannot be administered, who would come on a chartered flight every 2 weeks. When I was in Toronto, we had a patient who would come, he lived on a little island, and he would come by boat in the summer and by snowmobile in the winter. And he had actually fallen through the ice on his snowmobile a few times, just trying to get to his infusion appointments. And so it can become challenging. The other thing is this repetitive venipuncture can really wear out the vasculature for patients. And so sometimes we need to put PICCs and portacasts in patients. And again, this is a very thrombotically driven disease, so that's not a great practice. And of course, it affects patients' quality of life. They can't go for prolonged or international travel often, and they're thinking about the disease constantly because they're waiting for their next treatment. And so while we were so pleased and happy to have access to eculizumab, we still had a lot of unmet needs. Some patients actually just did not respond very well to eculizumab, and so complement was not totally blocked, so we had to increase doses. A cohort of Japanese patients actually have a polymorphism that binds right where eculizumab needs to bind, and so the drug is essentially useless for that population. As far as I know, we don't have any of those polymorphism patients in Alberta. And then there's also this mechanism called C3-mediated extravascular escape hemolysis. And essentially, if you think about that Plinko complement cascade and you think about putting the clamp at the bottom, well, all the mischief can still happen upstream. And so what happens is those C3 cells, they become loaded or opsonized, and the immune system gets smart and just takes them to the spleen to get destroyed. So instead of waiting for them to get destroyed in the vasculature, they have extravascular hemolysis. Convenience we've talked about, and then competition was really welcome in this space to drive down drug costs and motivate more rigorous trial methodology and a better understanding of complement diseases. So in steps ravulizumab. Ravulizumab has been approved here in Alberta since May of this year, May 2024, and essentially it was engineered by masterminds. There was 4 amino acid changes, and it basically helps to promote the half-life of this disease. So it reduces frequency of trough exposure and allows the drug to be given every 8 weeks instead of every 2 weeks. So it helps to reduce the annual cost, and of course, is a huge improvement in quality of life for patients. This was studied in 2 clinical phase 3 trials, the 301 and 302 study. The 301 study looked at the complement naive, so these were patients who had never been on complement inhibitors, whereas the 302 looked at clinically stable patients on eculizumab who were desiring a switch. This is the data from the complement inhibitor naive. The primary endpoints, there was co-primary endpoints of transfusion avoidance and LDH, and those were both met in this trial. And then the secondary endpoints looked at LDH, that FACIT fatigue score I mentioned, breakthrough hemolysis, and the ability to stabilize the hemoglobin, and those endpoints were met where there was a strong lean towards ravulizumab. Same thing with the arm of patients who were on eculizumab who switched over. The primary endpoint, which was % change in LDH, things were stable from that perspective, and the same thing with the secondary endpoints. Of course, patients, for the most part, are going to prefer this drug because it's administered every 2 months instead of every 2 weeks. 93% of patients preferred ravulizumab, and 88% attributed that to an improvement in their overall quality of life. 98% really enjoyed the ability to be able to plan more activities, and 64% actually thought that their fatigue control was a little bit better. Pegcetacoplan, so this is that C3 inhibitor. This works at the level of C3. It helps with the intravascular hemolysis, but it also helps to turn off that extravascular hemolysis. And I mentioned that's more of an iatrogenic complication when we block low down, and then basically that hemolysis happens more upstream through a different mechanism, extravascular going to the spleen. And so pegcetacoplan is helpful because it can get rid of both the intravascular and extravascular hemolysis. It is a sub-Q drug, but it is administered with a pump, and it is administered twice a week for most patients, and some patients will need to escalate to every 3-day dosing. This was looked at in a number of phase 3 clinical trials. The Pegasus trial looked at patients who had a baseline hemoglobin less than 105. And so these were patients who kind of had a suboptimal response to distal complement inhibition. And the primary endpoints here were met as well, which was change in hemoglobin. And same thing with the secondary outcomes, strong lean favoring pegcetacoplan, or at least non-inferiority for transfusion avoidance and change in baseline from a reticulocyte count. So we went from having not a lot of therapies and a very poor prognosis now to 3 different therapies that are available. And it's a very exciting time to be involved in the PNH space, especially being involved in research and clinical trials, because this is yet another different picture of the complement cascade. And you can see here the number of complement inhibitors in development. So at the level of C5, eculizumab, ravulizumab, which I briefly reviewed, but we also have crovalimab, which is a subcutaneous every 4-week treatment, polizumab and cemdesiran. This is a combination sub-Q treatment, and then eculizumab biosimilars are also coming. At the C3 level, we talked about pegcetacoplan, and we now have oral therapies for PNH, a medication called danicopan, which is an add-on therapy to eculizumab and ravulizumab. This is administered as a pill 3 times a day orally in addition to those IV treatments. And then factor B inhibition with iptacopan is actually a standalone treatment. It's a monotherapy, and it's administered orally twice a day. So this is basically harnessing very higher, much higher up in the complement cascade and the ability to use oral therapy. And then again, because of the audience that I have the privilege of speaking to, I really want to talk about thrombosis, because a lot of internal medicine groups are going to be managing the thrombosis clinic. And so thrombosis prevention is key, and that is with complement inhibition. So a huge take home, PNH if you want to prevent thrombosis, you have to start them on complement inhibition. Anticoagulation alone is not going to be enough. If you do have a situation where you don't have access to complement inhibitors, I would recommend starting anticoagulation. That is my personal practice. And once they're started on anti-complement therapy and you see that LDH come down really beautifully, then you can have a discussion about discontinuing that treatment, because we know that hemolysis is really what's going to drive the thrombosis. If patients have had a clot before complement inhibitors, then we can continue anticoagulation. Even after starting the complement inhibitor, usually patients will want that because the clots are severe, but this is sort of debated in the literature. And in terms of the type of anticoagulation, there's probably best evidence for warfarin, but I would say almost all of us use DOACs for convenience and patient preference. And if they've developed a thrombosis despite being on a complement inhibitor, you have to look for a provoking risk factor. Did they miss a dose? Was there something else that was kicking off complement? Pregnancy? Was it a really bad infection, vaccination? Was there something else that really was kicking off that complement cascade? And if that happens, really urgently start anticoagulation and consider increasing or giving an additional dose of complement inhibition. And so with all of that, I will leave you with my key take-homes. PNH, I hope you realize, is a rare hemolytic anemia, and it presents with really common signs and symptoms, which means it's a hard diagnosis to make, and you need to have a high index of suspicion. And so try to remember those catch criteria and have a low threshold for testing. Flow cytometry, readily available, relatively inexpensive, and can be ordered by anyone. Uncontrolled terminal complement activation drives the natural history and pathobiology of this disease. It presents with intravascular hemolysis, fatigue, dyspnea, renal failure, thrombosis, and thrombosis is the primary cause of death in patients who are untreated or undertreated, and complement inhibition reduces that risk. And the last is my appreciation for the complement community, both from a research basis and all the incredible patients and advocacy. As a result, we have new complement inhibitors that are coming. But we will need systematic global collaboration of PNH specialists to basically monitor and compare effects over time. And so again, if I've triggered, hopefully, thoughts about screening for a patient with PNH and you do end up, please drop me a line. I'm just going to be away with this baby for a while, but I'm still happy to enroll patients in our clinical trial, which is hopefully opening. This is an international PNH registry, which is basically going to look at all of the data for all patients with PNH, both on and off therapy. And then from an industry perspective, industry partners are able to, purchase essentially silos to manage that data. And with that, I will conclude and take any questions.
Thank you, Dr. Oliver. We're really happy you made it through without.
Yes, exactly.
There is still a time period.
Yes, exactly.
So I'll just kick it off by asking, as you went through the cases and all of the clinical presentations, I think a lot of us in the room felt like, oh, I need to go back and look at. So do you have a sense in the literature? I mean, you said 1 in a million in North America, and 1 in or 10 in a million across the world of missed diagnoses. Like, how many of my patients where we attributed their pulmonary hypertension to primary or other similar sort of presentations, do you think needs to be looked at? You said, there's that 10-year period where patients get missed. Is the first question, if there's anything in the literature in terms of going back and looking and how many were actually missing. And then the second question is really around, you talked about PDQ and that nice little checklist of symptoms. Has there been a correlation with going back and looking at that with treatment? Because it seemed to me with some of the slides you put up that fatigue wasn't as responsive to treatment as the other things, which are, more related to mortality.
So for your first question, I don't think we have a good sense of how many patients are missed, but we know it's a large proportion by the time they reach us, usually with a complication. It's getting better. And with regards to incidents, it comes in clusters. So we've had 2 in the last 4 to 6 weeks that we've diagnosed, but then, I've had a year of my practice where we didn't have any new patients. And so it is somewhat variable. And again,
people are thinking about it when
exactly. So hopefully it's, initiatives like this, getting to speak to an audience like this, that helps more people in more specialties to say, oh, maybe I should go back, like exactly like you said. So hopefully we'll be catching more of these patients, but I don't have a clear sense of numbers in terms of how many patients are missed and, potentially die from pulmonary hypertension, renal dysfunction, et cetera, before it's picked up. Your second question about the PDQ, so it's not validated. It's just a little passion project. So it's something that we're hoping to roll out kind of more widespread and hopefully validate. But the fatigue piece is so important because we, for the longest time, correlated fatigue with hemoglobin levels. And we know that's not the whole picture. It is complement activation that drives the fatigue. And so patients can have horrible fatigue, but their numbers don't look that bad. And so that was, again, another impotence for wanting to develop this questionnaire, to say there's all of these other facets that may kind of work into patients' fatigue, including treatment burden, right? When patients were mainly on eculizumab and having to go so frequently for treatments.
Yeah, Peter.
So I think it's generally thought that the early part of the complement cascade is more important for the immunity than just the terminal part. Are there like a greater degree of infections? I wonder about the adverse events with the new C3.
Yeah, excellent.
Can you repeat the question if you don't mind?
Oh, sure. And so the question was, when we block downstream, we have a better sense of that being involved probably in the terminal hemolysis, but blocking higher up, does that increase our risk of infections? Because we think that those portals, those different pathways I mentioned, are really involved with the immunity response. That's not what we've seen in clinical trials thus far. So the risks of meningococcal infections, as long as patients are appropriately vaccinated and prophylaxed, tend to be very similar to what we see with distal. And we're also seeing that in the danicopan literature. So that's that dual complement inhibition, C3 and C5. We're not seeing, as far as we know, a huge increased infection risk. But I, asked the exact same question. And then, when we go and talk about PNH in patients who are really poorly managed or have really kind of tough to treat or refractory disease, the question then becomes like, I know right now from a cost perspective, it's not feasible to block complement in multiple different ways, but is that something that's coming in the future? Are we going to be blocking factor B and C5 or C5 and C3 and factor D? I don't know. And does more inhibition of complement lead to increased infection risk? It's still a question mark.
Yeah, Peter.
That's fabulous. So this ravulizumab is being considered in kidney transplant in delayed graft function to mitigate ischemia reperfusion injury. So my question to you is, in your clinical experience using it, because our transplant patients and some of the other immunosuppressives have the potential for hemolytic anemia and their immunosuppressive marrow impact, do you recommend enhanced monitoring if you are in a trial, which is the plan, with ravulizumab or DGF post-transplant to be monitored? Like, how do we differentiate the hemolytic anemia?
So,
Again, if you can repeat.
oh, sure. So the question was, there's been exploration of ravulizumab now in obviously other spectrums outside of, or so I should say complement inhibition, namely terminal complement inhibition outside of the PNH space. So in the transplant population, for example, but we know hemolytic anemia can also be seen post-transplant with calcineurin inhibitors and other effects. So do we need to increase monitoring? And so I wouldn't go ahead and screen all of your patients for PNH prior to. If they get started on ravulizumab, that's the treatment for PNH, so that's going to be helpful. But the mechanism should be different, right? We should not be seeing hemolysis as a result of complement inhibitors. That should be improving things. And then we've also seen a lot of use of ravulizumab in the post-transplant space for patients with atypical hemolytic uremic syndrome. So this is also an improved indication for that as well. And those patients tend to do quite well in the data that we've reviewed. And so they don't need any particular monitoring especially from an infection perspective, other than very, very clear education about meningococcal infections. But I don't think of this the same way that I think of rituximab or cyclophosphamide or other things that cause myelosuppression and really increase infection risk. It's really specific to those meningococcal infections, which, like I said, you can mitigate with vaccination and prophylaxis.
Yeah.
Thanks for a really, really excellent talk. And obviously in nephrology with the whole C3 glomerulopathy field, but this is a rapidly evolving space in terms of complement inhibition for hematologic C3GM. A lot of these novel drugs that are looking at, factor B and D inhibition and things like that. Do you see a role, or have you heard anything things about that evolving into sort of the C3 glomerulopathy space?
So I'm not as intimately familiar with that literature, obviously, but oh, sorry. For C3GNs, is there data that's emerging or evolving regarding some of the more proximal complement inhibitors, namely factor B and factor D? So I was saying I'm not particularly familiar in the C3 glomerulopathy space, but I'm sure they're coming. It makes sense to target C3, and that data I think is available. But for factor B and factor D, I'm not quite sure, but I expect they'll be coming because again, as we get more and more spoiled with options, I'm sure patients are going to want oral preferences, subcutaneous preferences, and we'll have to see if the mechanism is similar. But we know all of these diseases are involved with overactivation of the complement cascade. So from a pathophysiology biology perspective, it does make sense.
Just out of curiosity, for the subcutaneous, why a pump versus injection? I mean, it just seems, and it would be much easier when you look at IVIG and other subcutaneous.
I don't know. So that is how it was designed.
Yeah.
I think there is some movement towards making the modality of treatment a little bit easier for patients and maybe forgoing the pump. Now, I would say a majority, it's kind of hard to say it because it depends on when the patients are diagnosed, but they can give this medication on their own. They can learn to give it at home. But certainly for elderly patients or patients with needle phobia, that does become a barrier.
Other questions? Or online? Okay, perfect. Before people sign off, I do have an important announcement. But on behalf of the department, thank you for an outstanding presentation. These conditions are so important from a general perspective. It clearly, spans in multiple specialties, and so this was really helpful. Thank you.
Thank you again for the invitation. Thank you.
So I just want to make a quick announcement.